Hello. Today, my presentation is on decision-making in structural heart disease. This lecture was given on November 4th at Mount Sinai Fuster Heart Hospital Cardiology Grand Rounds. Here are my disclosures. Well, I would start by saying that decision-making in coronary artery disease is probably pretty straightforward. You can see that here, it's like a straight row. If you have a lesion and patient have symptoms meeting appropriate criteria, it should be revascularized. However, in structural heart disease, you can imagine it's a lot more convoluted, a lot more things to keep in mind when evaluating the patient. The reason being is that we have a true multidisciplinary heart team where we focus on the patient. And you can see that here, there are many disciplines involved, not just in cardiovascular medicine, but also in other subspecialties as well. So how do we make decisions depends on a number of things. First, are patient factors. What is the surgical risk of the patient? Any comorbidities or frailty? Are there social or family factors involved? What are the anatomic factors? Is it single or multi-valve disease? What kind of transcatheter options would be suitable? Imaging is critically important in structural heart, so we need to look at how that would impact procedural safety and treatment options. Now, in terms of procedure itself, you need to look at access, how the device would navigate in the heart, and how the position. Is going to be one device or multiple devices? How to standardize and optimize the procedure so you can make it reproducible and teachable? And finally, what is the anticipated outcome? Is it for long term? Is it for short term? Or would it be futile? So let's look at the aortic valve. You can see that the guidelines already clearly established that TAVR and SAVR are for patients who are 65 or older. And you can see that in the European guidelines, it's 75 or older. There are already published papers such as this one looking at the workflow in patients with aortic stenosis. However, we know that in the United States, actually younger patients are increasingly getting TAVR, and you can see that here where SAVR is declining. Clearly, there are trade-off between the two options. You can see that here, while SAVR has less paravalvular leak, less conduction system disorder, TAVR does offer the benefit of less AFib, bleeding, or acute renal injury, faster recovery, and shorter hospital stay. However, you can see that the durability may be still somewhat up to 10 years, perhaps. Coronary access and aortic valve intervention might be more challenging with TAVR. So this seminal review from European Heart Journal outlines the lifetime management journey of these patients, that the younger you are, if you have isolated surgery or TAVR, initially you'll likely have at least more than one reintervention in your lifetime versus if you start your journey a little bit later. We know that the TAVR explant is actually the fastest growing operation in the United States based on the STS database. And you can see both due to structural valve deterioration and non-structural valve. At the same time, redo TAVR is also increasing in numbers. So you can see here. However, TAVR explant is relatively unattractive due to high stroke rate and mortality rate. So it remains to be seen how we can make this procedure safer for our patients. In terms of valve-in-valve TAVR or patient with failed surgical valves, there are a number of factors involved, as you can see in this review. However, with failed TAVR, we typically would diagnose them with multimodality imaging, and based on the mechanism of failure and the surgical risk of the patient, we would offer them either surgery or TAVR explant versus percutaneous treatment, such as percutaneous closure for PVL or redo TAVR. So let's first look at the workup involved in TAVR or SAVR. You can see that here a meticulous CT scan is necessary. Look at the aortic root complex in terms of the location and distribution of the calcium at the annulus or the leaflet. You will also want to see what the aortic root looks like in terms of how the valve will fit, especially in younger patients, in terms of coronary obstruction risk or aortic root injury risk. Currently, there are 3 commercial available devices available in the United States for TAVR, 1 balloon expandable and 2 self-expanding. Each of them have different sizing criteria, and you can see that here, based on the sizing charts provided by the manufacturer. As well, the access is critically important in terms of decision-making, where to stick the femoral artery to avoid potential vascular complication. Now, the deployment of the SAPIEN Ultra resilient valve itself is not just simple blowing up the valve. It's actually a lot of thought put into it in terms of sizing, how much inflation in the balloon, where to position the valve, final target position that you're aiming for, and whether you pre-dilate or post-dilate it during the procedure. Because we know that halt or hypoattenuated leaflet thickening is associated with underexpanded transcatheter valve. So you can see that here, if you have an underexpanded valve, not only you have more halt, but also potentially increased mortality in this seminal paper. And so what we typically do now is what we call a double tap technique for balloon expandable valve, where we optimize the valve expansion afterwards. You can see that clearly here in this fluoroscopic comparison, but also in self-expanding valve as well, we would post-dilate to optimize the valve frame expansion. And this is typically done under an aerial caudal projection, where we show the short axis of the aortic root annulus. We also recently published a work showing that after TAVR with an undersized SAPIEN 3 with overinflation, you can actually optimize the valve expansion, particularly making it more cylindrical and less underexpanded. By undersizing and perhaps downsizing even, we actually can facilitate redo TAVR in these patients, facilitating lifetime management. What is increasingly important now is to use CT simulation to perhaps guide the first TAVR implant to facilitate redo TAVR. And these are 2 studies that are conducted by our group, showing that the higher the valve you are for SAPIEN 3, and the larger you are, perhaps your likelihood of redo TAVR goes down. And with the Navitor system, you can see that here, you really want to optimize your index implant depth, and then your second valve would be able to be positioned in a different location depending on your need to avoid coronary obstruction. So in summary, the decision-making on the aortic valve is really TAVR versus SAVR, anatomic versus patient risk, short-term versus long-term gain, this need to optimize the index procedure, and finally, facilitate lifetime management. Now, what about the mitral valve? It's certainly more complex because not all primary MR is the same. And you can see that here in the 2020 AHA ACC guidelines of primary MR, surgery is still the gold standard. Now, not all secondary MR is the same. You can see here ventricular SMR, but versus also atrial SMR, which has a poor prognosis if untreated. And you can see that here in the AHA ACC guidelines, for secondary MR, that transcatheter edge repair would be reasonable in patients with suitable anatomy. And this is also highlighted in the European guidelines as well. So what we are talking about with decision-making in mitral valve is such that when primary MR surgical repair should be the gold standard unless the patient is higher prohibited risk. In secondary MR, though, patients need to be medically optimized. And with transcatheter edge-to-edge repair or TEER would be a class 2A indication in suitable anatomy. Surgery still plays a role, but more class 2B, especially if you need to have concomitant CABG. However, in atrial SMR, I would say that you need to also fix the AFib. So surgery where you actually can do the mitral valve repair and MACE procedure and LA exclusion may be more definitive in appropriately selected patients. And don't forget the TR, because if it's mild or greater, you need to consider fixing both mitral and tricuspid valves. In terms of the decision-making algorithm, assuming patients already optimized, you really have to figure out whether you can reduce the MR to 1+ or better. If you can, then I think transcatheter mitral valve repair in most cases will be edge-to-edge, will be a reasonable option. If not, then really the patient should be considered for TMVR. However, the patient will need to take anticoagulation, and also the anatomy will have to be feasible. And there are currently 2 devices available for clinical trial in the United States, be a transeptal or transapical approach. Here, the number of devices are currently in clinical trials. Some of them are CE marked already. But if you look at the global TRISME registry, majority of the patients, unfortunately, you can see 7% were screened out. And the majority reason being inadequate anatomy, particularly LVOT obstruction, in addition to sizing constraints. So as a result, the mitral clip has been around for over 20 years, with lots of data being presented over the past 2 decades, and also newer generation devices being available. And you can see the current iteration is the MitraClip G4 system with 4 clip sizes to choose from to optimize the repair and customizing it. However, the decision-making with Mitral TEER typically involves anatomy. Can you anticipate the MR reduction to 1+ or less? What about imaging? Is TE adequate? Procedural factors include 1 or more devices in terms of the level of difficulty of the procedure. AESD closure may need to be considered, particularly in the context of severe TR, RV dysfunction, and pulmonary hypertension. And the final question, what is our goal of therapy? Is it to cure MR? Is it to improve symptoms, or simply palliation? So in terms of clip sizes, I won't belabor the technicality here, but if you have long enough leaflets, you should use the longer and usually the wider clip. However, if your annulus AP dimension is small, be careful of puckering of the annulus, and as a result, having MR on either side of the clip. We typically use 1 clip to start, and that should be sufficient to reduce the MR to 1+ or better. You, however, want to consider 2 clips if the jet will be broad. And finally, we typically like doing now the wide clip followed by a narrow clip to allow the clip to be close to each other and reduce the leak in between. In terms of primary MR, you typically want to bring down the entire flails or prolapsing segment. If the gradient allows, you typically put a second clip to stabilize the repair. If the gap is too big, you might want to put the first clip next to the really big gap to allow you to set the bring down the flail or prolapse to then go for the pathology. If the leaflets are really long, you may see a canting of the clip, but that is expected. Don't grasp cords. You should grab the leaflets to risk, otherwise you risk SLDA or leaflet detachment, and finally grasp the leaflet in diastole. Now, in secondary MR, it's a little bit different. If the leaflet is long, we still like to prefer the longer clips because you can grasp more easily, plus you can achieve indirect annuloplasty. If there's poor coaptation reserve, you might need to clip first independently, usually anterior first, then posterior. You want to grasp as much leaflet as possible, as I mentioned before. In atrial MR, you want to stay shallow in the ventricle to avoid getting stuck. You really want to aim for 1+ or better MR, in my opinion. And of course, sometimes with advanced cardiomyopathy, you might want to watch for acute afterload mismatch, and so support the patient hemodynamically. So here is how the evaluation should be on echo. You can see that we do a bicombinatorial X-plane, the LVOT view, and sweep across the entire valve to look at the jet location, severity, and the underlying anatomy for clipping. You also want to do a 3D on-force view, which is a surgeon's view to look at the pathology and the jet location, and also to orient the valve properly for the procedure. Fluoroscopy is also critically important. You can see that here, by doing so, you really streamline the procedure, improving its efficiency and safety. And so I'll give you an example of this atrial SMR case, where you can see that the patient has severe SMR due to atrial fibrillation. And so we put 1 clip laterally, and you can see it's a pretty good result. It looks like a mild MR, really, with improved airway pressure, low gradient, pulmonary vein flow improved. The question is, would you consider putting a second clip? And so I would say in atrial SMR, we would in this case, because what we worry about is that the AFib persists. So you can see the annulus dilate and then the MR comes back in time. So what we like to do is put a second clip, and actually right next to the first one, this is an XT now with the one with the MR, and you can imagine this will be a durable repair. Now, what all anatomies and secondary MR appropriate for mitral clip? You can see that here, if they have really advanced cardiomyopathy with a proportionate kind of changes in the regurgitant volume and regurgitant EROA, you should definitely not consider it. Now, what about functional mitral stenosis? This is certainly a limitation of TEER, and you can see that with primary MR, high gradient is bad, but if it's high gradient and secondary, it's not so bad. You certainly want to avoid it if possible. This is the EXPAND G4 registry that is global, primarily conducted in the United States, that show that most of the time under core-lab adjudication, your MR1 plus will be achieved near 91%. However, even in patients with more complex anatomy, such as risk of stenosis, you can see that 97.4% still 1 plus MR, or if you case of really just palliation because you don't expect the MR reduction to be adequate, still around 75% as achievable. I want to turn attention quickly to MAC, or mitral annular calcification. You can see that here they're very complex and heterogeneous group of population. There are some documents that published now talking about how to manage and work up these patients. Certainly, they should be referred to a reference mitral center. And you can see that here there are a number of options available in these patients on decision making, including surgery, both repair and replacement, hybrid approach, and of course, transcatheter approach if they are anatomically feasible. So the challenge of mitral valve intervention with MAC is that it makes etiology. You can have pure MS, pure MR, or combination of both. These patients typically have very eccentric, non-conforming mitral annulus. The protruding calcium or thickened leaflets can limit repairability. Of course, they have small ventricles, so LVOT obstruction risk is real with TMVR. And certainly, we don't know what the potential interference would be with a TMVR device in terms of fixation and deformation, and even the risk of migration. So patients with MAC-related MS should likely be replaced in terms of the valve. However, if they're mostly driven by MR, you could consider surgically repair them or even transcatheter repair as well, in addition to replacement as an option. So in summary, the decision-making on the mitral valve is really, is it surgery versus TEER versus TMVR? What are the patient risks versus anatomical imaging risk? You really want to aim for 1 plus or better MR with TEER, but definitely set expectations, especially with complex anatomy or patient is really for palliation. TMVR does eliminate MR, but unfortunately has high screen failure rate and more intensive workup process. Limited transcatheter options, unfortunately, right now to treat MS and MAC. And don't forget multivalvular disease, because you want MR and TR to be treated, and it's including surgery or stage transcatheter intervention. So what about a tricuspid valve, which is now the less forgotten valve? So you can see that very few patients in the United States are undergoing isolated tricuspid valve surgery due to the morbidities of these patients. And we published a review paper on this regard on all the spectrum of tricuspid valve surgery. Now, when may transcatheter over surgery be preferred? You can see that based on the clinical trials, they typically at least intermediate surgical risk. They have favorable tricuspid anatomy on imaging. Lead themselves are not a contraindication, but we need to select case by case. You want to avoid severely dilated annulus or poor RV function because they are really too advanced for any intervention. So assuming the patient's medically optimized, what is the algorithm here for TEER versus TTVR and tricuspid, because now both therapies are approved by the FDA. So the first question is really, can we reduce the TR to 1 to 2 plus? And that it depends on the leaflets, the mobility, the gaps, the lead presence, and also imaging difficulty. If you can achieve TR reduction satisfactory, you should consider TEER because it is safer with quicker recovery. However, if you don't think so, then you really have to think about replacement. And so the question is, can the patient take anticoagulation? If they can, then what about the anatomy? If they're feasible, then they should be considered for replacement. This is my own assessment of T-tier difficulty. You can see it based mostly on anatomy and sometimes also imaging difficulty, and we'll break it down to green, yellow, and orange, red, green being the most straightforward. And so you can see an example here how the anatomy really dictates the difficulty. So on the left side, you can see the leaflets are well co-op in terms of reserve, so you likely be able to do the procedure relatively easily to grasp the leaflets. But if they're asymmetrical, you might have tougher time doing the septal leaflet because it's tethered. And if the leaflets are flat like that, it's going to be extremely challenging, and you likely have to independently grasp the leaflets to be able to bring it closer together. The Abbott TriClip system, you can see that here is similar to the MitraClip system, but some modification with the delivery catheter is still 4 different sizes. This was the first commercial case done in Mount Sinai. You can see, despite being a quadricuspid valve, you can typically do, in this case, 1 clip, and you can bring the TR from torrential to mild, and the patient can go home the next day. This was just presented at TCT 2024. I did that on behalf of our co-authors, showing that the entire TRILUMINATE randomized control trial show now improved KCCQ score and 6-minute walk distance at 1 year, further confirming the benefit and quality of life in these patients, both subjectively and objectively. However, at 1 year, there remains no difference in terms of mortality or heart failure hospitalization. So here is an example. Clearly, the patient is not a T-tier candidate. You can see that on the left side, you can barely visualize the leaflets. On the right side, you have a lead and large coaptation gap. So you really need to consider replacement in these cases. So the pros and cons of tricuspid TEER is that it's excellent safety profile. Pacemaker and bleeding risk are rare. Patient go home typically next day. The TR reduction can be maintained at 1 year, but the more TR reduction you can get, the better you are with the end up. The limitation right now is suitable anatomy in terms of and imaging quality. So it depends on the gaps, the leaflet tethering, the morphology, and also the presence of leads and their locations. TR may recur though in reality, given the difficulty in maintaining optimal medical therapy in the real world, and we've seen patients unfortunately come back with that. So it's very important to stay vigilant to managing these patients closely. Now, the Edwards Evoke transcatheter valve replacement system is now FDA approved. You can see that, in fact, there are 4 choices now in terms of sizes. And you can see that here, this is a echo-guided fluoroscopic assisted procedure. You can see these anchors actually capture the leaflet. That's how they fixate of this valve against the native anatomy. And you can see that here, once you deploy successfully, there's no TR to worry about. And this is done, you can see, using 3D reconstruction on confirming the leaflet capture before you deploy the valve. However, it was a bit surprising to see that the TRISCEND 2 randomized trial presented just at TCT and also in the New England Journal, showing that there was no difference in mortality or hospitalization at 1 year, despite TR elimination, which you see that here really almost 100% of patients do not have significant TR. Of course, these patients also have significant functional improvement versus the patient on medical therapy only. So the pros and cons of TTVR is really, despite elimination, there was no impact on hard clinical endpoints. So the question is, do you really need to eliminate TR? Of course, psychologically, it makes you feel good. The anatomic legibility is a concern. The annulus can be too large, leading to screen failure, although with the 4 different sizes, it's increasingly less common. Anticoagulation need and duration is certainly critical in the right-sided replacement valve. Pacemaker risk and management strategy is a concern in the TRISCEND 2 and some of the registry. The pacemaker rate can be as high as 30 to 40%. And there is a concern also acute RV afterload mismatch and prolonged hospital stay with these patients. So we typically bring them in ahead of time, put them on IV Mirinone to prehab and precondition the right ventricle, and also diurese them aggressively to make sure they don't get volume overload and be able to tolerate the TR elimination. However, these patients typically stay 3 to 4 days, as you saw in the trial, versus next day discharge with tricuspid TEER. So in summary, the decision-making on tricuspid valve is that the volume optimization is key prior to imaging evaluation. Treatment options really depend on anatomic and imaging factors. The transcatheter repair versus replacement, they both improve functional status, but not at 1-year mortality or heart failure hospitalization. Now, surgery remains an option in these patients who are not candidates for transcatheter intervention. In fact, we recently performed surgery on a patient who was not a candidate for either repair or replacement option. So we took the patient in the operating room and replaced the valve, and the patient is doing well so far. But of course, it has to be done in experienced centers like ours. And of course, you should not forget about multivalve disease, which come to my final point on patients with multiple valves. Diseases are now increasingly common, being referred to our clinic. And these patients really need a heart team discussion in the context of transcatheter options being available, depending on which valve and also what surgical risk profile these patients have. So for example, aortic valve, we know that TAVR is indicated across all surgical risks. Mitral valve, however, TEER is only the higher prohibited risk in primary MR and rarely no stratification risk on SMR. Tricuspid valve, typically the trials have been dictating at least intermediate surgical risk. So, but also one of the conundrums lie in diagnosing the severity of the multivalve disease, which one is severe, which one is moderate, and how do you figure out whether they're clinically relevant. The decision-making also depends on anatomic factors because one or more valves are amenable to transcatheter intervention or not. What are the anticipated results of such an intervention? As I mentioned before, imaging is critical in terms of what transcatheter options are available, including for mitral valve and tricuspid valve, especially given they are more imaging intensive. Procedural factors, we need to take into consideration the difficulty of the surgery versus transcatheter intervention and how to time the staging of these interventions. The risk of multi-valve surgery versus single valve surgery is real. So often we may take a hybrid approach where we convert a multi-valve surgery into a single valve. So for example, we might do a TAVR first, and if the mitral valve cannot be intervened percutaneously, we would consider doing a surgical mitral valve repair or replacement. So let me give you a case here where you have an 82-year-old veteran, certainly have several comorbidities, and the patient is actually a primary caregiver for his spouse. And you can see that this patient certainly has severe aortic stenosis and severe secondary MR by echo. And you can see that with TE, the TEER is an option for this patient with secondary MR. Thankfully, in terms of aortic root complex, also appear feasible for TAVR via transfemoral approach. So the question is, would you do double valve surgery in this patient? If you consider transcatheter option, would you do TAVR first and then fix the MR afterwards? And if you do, when you fix it, do you believe that MR will improve because it's secondary? If you don't think the TEER would be suitable, let's say hypothetically, would you consider TMVR? Would you consider a hybrid approach? Do the TAVR first, come back and repair or replace the mitral valve? And what about would the first transcatheter valve in the TAVR position matter in terms of the choice of valve? So in this case, the patient underwent TAVR with an Edwards SAPIEN valve. You can see that, however, unfortunately, despite that great result with the aortic valve, the mitral valve still have moderate to severe. And so the question is, what do we do? And this is despite optimal GDMT. So what we decided to proceed with this HLX repair, you can see that here with one NTW, you really took care of the MR from severe to just trivial here. And you can see that the 12-month follow-up, this patient has significant symptom improvement, no hospitalization, and still with a normal transcatheter aortic valve. So the final take-home messages of this lecture is that decision-making in structural heart disease is complex. Recommendation really depends on which valves are affected and looking at patient, anatomic, imaging, and procedural factors. Surgery remains an important option in low-risk patients where transcatheter intervention remains suboptimal, and this requires heart team discussion. Procedural optimization to confer durable outcomes, I think, is key in all different interventions. And finally, the management of multivalve disease and transcatheter device failure, in my opinion, will become increasingly common. So on that note, I'd like to thank you very much for watching this lecture and have a good rest of the day.